Hello, I'm Dr. Nicholas Tedesco D.O, Associate Program Director for Good Samaritan Regional Medical Center's Residency Program. Today I'll be presenting on the topic of Revision Total Hip Arthroplasty as part of our ongoing online didactics that will supplement our formal in-class learning and case presentations. As usual, I do have a disclosure that I own stock in an orthopedic rehabilitation company. However, it has nothing to do with this topic or any of my topics presented. The number of cases of total hip arthroplasty in the United States has been growing steadily over the last 20 years. As a result, the number of revision cases are going up as well. In 2010, there were 43,500 revision surgeries, and those numbers are expected to exceed 60,000 in the next few years. A lot of this stems from the fact that we're doing this more often, we're doing it in younger patients, we're doing it in more complex scenarios, and therefore the revisions are becoming more common more often and becoming somewhat of a public health burden. The most common indications for revision total hip arthroplasty include mechanical loosening, infection, and hip instability. The acetabular component is involved in greater than 50% of all of the revision surgeries. 1.6% of hips are revised within 1 year of the index procedure, usually for infection, mechanical failure including dislocation, fracture, metal ion release or metallosis, or other reasons. So preoperative considerations once you have a hip that's gone wrong and you're starting to consider having to redo it. First thing you have to do is take a good history. Groin pain tends to be acetabular component issue. Thigh pain tends to be femoral component issue. Popping or clicking can be hip joint subluxation or a soft tissue failure around the hip. Squeaking can be seen in ceramic on ceramic mismatch or even some of the other implants as well, but much less common than the ceramic. I've included here a link to a YouTube video. I encourage you to watch it because the squeaking hips are rather significant, and it is a problem severe enough that if the patient is unfortunate to have a banshee screaming at them through their hip, this will need to be revised because it's certainly no way to live once you watch that video. Stinchfield sign is a physical exam sign that shows worsening of groin or deep gluteal pain with hip flexion. That's because as the patient lies back flat and you have them essentially do a straight leg raise, that increases their joint reactive force as they contract those muscles and pull that hip harder into the pelvis. Therefore, if you get this in an artificial hip replacement, it tends to mean that excessive loads are being transferred to the pelvis, and so there's probably an acetabular component problem that's going to need to be addressed. If the patient tends to have constant pain or night pain rather than functional pain, this usually is a harbinger of infection. Startup pain, which is pain that gets worse when a patient goes from sitting or lying to standing, and with the beginning of activity that improves as activity continues, is usually a harbinger of loose components. And that's because as those components are loose and toggle, when the patient goes to get up, the impact into the bone once those joint reactive forces increase hurts. But then as they walk, they're basically self-impacting those implants and seating them into the bone, so the pain tends to get better. But as soon as they come to rest again, it's a temporary impaction, it's a temporary press fit basically, so they sort of loosen up again, then the startup pain starts again the next time they get up. In terms of infection, this is unfortunately one of the most devastating problems that can happen in an artificial joint. All patients preoperatively should probably have a dental evaluation to identify any possible focus for infection. Maybe not a formal evaluation with a dentist, but in the office you should be checking patients' teeth at least superficially to see do they have good dentition or poor dentition that may require further workup and management before considering a hip replacement because of the degree of bacteria that get into the blood system through the mouth. Additionally, urology evaluation. Again, this is more just taking a good history. Do patients have urinary retention? Do they have a history of BPH? Do they get frequent UTIs? Things like that that again could be sources for infection, urosepsis, anything like that that may increase the risk of septic hip replacement. Any patients with a cardiac history or peripheral vascular disease should be evaluated by a cardiologist or vascular surgeon respectively, again because of their issues with healing, with wound complications, poor blood flow, increased risk of infections, all kinds of problems. An ESR typically normalizes between 6 and 12 months after a hip replacement, so it may not help in early infection or within the first year. CRP tends to normalize within 3 months, but again, a hyperacute or immediate postoperative infection, unfortunately, it's of no help. It's going to be significantly elevated just from the surgery itself. So you need to look at other things, whether it's an actual aspiration of the hip or other parameters such as blood cultures, things like that. However, a combination of ESR greater than 30 and CRP greater than 10 is the best indicator for infection, but this again should be confirmed with hip aspiration. It may be more valuable for excluding infection with normal values than including infection with abnormal, because certainly inflammatory conditions, postoperative conditions, or trauma can cause raises similar to this. So you do need to make sure that you're dealing with the right problem before you presumptively treat. You need to differentiate infection from aseptic loosening, and one of the things that can help with that is an indium or a tagged WBC labeled bone scan. The technetium uptake is inhibited by the infection, so it will be cold, whereas it will also be hot in aseptic loosening. Additionally, the tagged WBC scan will show how the white blood cells are localizing in the body. In chronic aseptic loosening, typically it's not very immunologically active, so the white blood cells won't be localizing to the hip, whereas in the presence of infection they will. If the hip is to be aspirated to rule out infection, you want the patients off of antibiotics somewhere between 2 and 4 weeks prior to performing that procedure, because of the risk of essentially plating what you have with antibiotics in it, which is going to kill anything you might potentially culture. You want to aspirate only if the ESR and CRP are elevated and the index of suspicion is there. You can consider reaspiration if there's a highly probable infection with a negative aspirate. Intraoperative frozen section should always be done on patients at the time of revision to screen for an occult infection. This is done by simply sampling the tissue directly around the hip joint, sending it to the pathologist for a frozen section, who will then look at PMNs per high-powered field. 0 to 5 is usually not infected. Greater than 10 is almost always infected, and 6 to 10 is that gray zone where you have to go off of the clinical behavior, the appearance, your preoperative labs. So that's where it becomes much more of a clinical diagnosis based on your index of suspicion. If you have an abnormal ESR or CRP, but low suspicion of infection, then reevaluate in 3 months. 20% of patients with multiple arthroplasties that get one infected will get another one infected. However, only 36% of those will grow out the same bug. So what that suggests is usually there are patient risk factors at stake when they get an infection, which means they're high risk for another infection. Unless there's a strong reason to do otherwise, the single-stage revision is probably the most appropriate treatment for an infection at the site of a newly performed total hip replacement or a DARE procedure, so debridement, antibiotics, and implant retention for total knee replacement, if this is picked up within 3 weeks of the index surgery. You don't necessarily need to pull all the hardware out and put new hardware in, because it may not have gotten completely seated as of yet. Total knee and total hip infection rate the first year postoperatively is only about 0.37% in healthy patients, but 4.66% with a BMI greater than 30, 9.8% with a BMI greater than 30 plus diabetes. So diabetes mellitus independently doubles the risk of infection, and this is a huge deal, especially if they're uncontrolled. A 10% one-year infection rate is unacceptable for how devastating of a complication and deadly this can be. Heterotopic ossification is another potential reason for hip revision surgery. There's an increased risk of this if the patient has DISH or diffuse idiopathic skeletal hyperostosis, hypertrophic osteoarthropathy, prior hip arthrodesis, a direct lateral or Harding approach, post-traumatic osteoarthrosis, history of any heterotopic ossification elsewhere in the body, or a Brooker grade 3 or 4 heterotopic ossification around an existing total hip arthroplasty. The Brooker classification looks at heterotopic ossification formation around a total hip on the AP radiograph. So grade 1 is just cloud-like formation out in the soft tissues. Grade 2 is where you have it start growing out of the femur or the acetabulum with greater than 1 centimeter of distance between the bones. Grade 3 is less than 1 centimeter, and grade 4 is complete ankylosis and connection of the femur to the pelvis via bone formation. If you want to deal with this in terms of prevention and you do radiation ahead of time, or if you're revising it because of heterotopic ossification and you want to radiate it afterwards, depending on the timing compared to surgery, whether or not there's bone ingrowth or not, if you're still relying on bone to ingrow into the femur, you'll need to shield the proximal femur and the acetabulum to avoid destroying the bone and therefore the ingrowth potential of press-fit implants. So now that you've determined the sorts of needs for a hip replacement revision, what might be going on, what things you need to consider, why you might be doing this procedure, now you have to start planning for it. You always want to attempt to acquire prior x-rays or implant records and operative reports to help tell you what's in there, what are the sizes, and what did this used to look like in case there is a morphological change that would hint at loosening, fracture, eccentric polyethylene wear, anything else that might be changing over time. Additionally, you want to evaluate the patients for risk afterwards in terms of healing, in terms of bone ingrowth, in terms of infection, all of those things. And so one of the things that can help is total protein less than 6, albumin less than 4.5, and a total lymphocyte count less than 1,200 may indicate poor nutritional status and therefore infection or poor healing risk. Total lymphocyte count has the weakest correlation with nutrition status in the elderly, and albumin half-life is only about 20 days, so it's a poor indicator of acute malnutrition, meaning if a patient just got sick last week, hasn't eaten for a week, they're malnourished. But their albumin may be normal because prior to that they were healthy. So you do need to look at how the patient has played out clinically and what might be the best test of choice to determine if this patient needs to be nutritionally and medically optimized prior to considering a big surgery like this. The next thing is you do want to check leg lengths, whether it's with formal radiographs or in the clinic. You want to see if there's something going on that may tell you that you need to shorten or lengthen a leg. Additionally, you need to look at what problem you have confronted with where you may be obligated to lengthen the leg. If that's the case, you need to rule out spinal stenosis or radiculopathy in the patient by taking a good history, or else you end up with a double crush phenomenon where they have an impinged nerve in the spine. Then you lengthen their leg, so now you impinge the nerve, usually at the soleal arch in the leg, and now you've got a double crush and the sciatic nerve goes out from overstretching. Because of that, as a general rule, you don't want to stretch the leg greater than 3 centimeters, which is about 1.25 inches, 1.5 inches, somewhere in that region. So once you stretch more than that, you run the risk of really harming that sciatic nerve. If you get a patient post-operatively, had no problem, all of a sudden the sciatic nerve goes out, especially if it's delayed, consistent with a traction neuropraxia, first thing you want to do is extend the hip and flex the knee. Get that tension off of the sciatic as much as possible. If that resolves it, then you can observe it and see if the patient can just stay in that position of comfort to keep the nerve while it accommodates to this new stretch. Or you may have to go back in there and revise things, shorten the leg, osteotomy, or a constrained liner, whatever you have to do in order to shorten it appropriately while still maintaining hip stability. You want to evaluate the femoral bow or the presence of distal implants using entire femoral x-rays, especially when a long stem prosthesis is needed, because those things may impact what you're able to do with your instruments. A double down or Lowenstein lateral radiograph is a way of getting a lateral femur x-ray without having to do a cross-table lateral, which sometimes is very cumbersome and uncomfortable for the patient or not possible depending on the technology in your clinic. And a frog leg position to get a lateral of femur could actually dislocate the prosthesis. So you don't want to do that either. So this is the way of evaluating the lateral femur, which is essentially, as you look at that pelvis, you have the patient just lie supine, but then you angle the beam 45 degrees off. So it's just like an iliac oblique view of the pelvis that gives you a lateral view of the femur without having to actually manipulate the patient. When you go to do your surgery, you want to try and use the previous incision because of poor healing with parallel incisions, especially if less than 3 months from the index procedure. So if someone went anterior, you want to try and revise them anterior if possible. Likewise, posterior, stay posterior. just because you don't want to devitalize a skin bridge that then would necrose, that will either lead to infection or needing flap and graft closure. You want to retain components wherever possible. So if they're stable, they're well fixed, they're in good alignment, there's no infection presence, leave it. You don't want to damage tissue that doesn't need to be damaged. If the components are model block, the entire thing has to come out. If they're modular, you may only need to replace a certain part, but then you'll need to have the correct tools available to dislodge those modular components. You want to be prepared to use longer head and neck lengths or increased offset liners to restore or increase tissue tension to make sure that you're able to get them stable post-operatively now that you've gone back into this hip and created multiple more soft tissue defects when they already had all this scar tissue from their previous surgery. So patients lose soft tissue tension the more surgeries they have. So you have to lengthen the leg, you have to increase offset to help accommodate that. You want to have plenty of bone graft ready and always have a plan B or even a plan C, D, E, F, G. You may end up way down the line if things are going wrong or not what you expected. So make sure you have everything there that you may need. When you're evaluating the patient in the clinic, you want to look at what kind of gait they have. If they have a Trendelenburg gait, they have poor abductor function. That means you may need an EMG to see if they have some sort of neurologic issue. You may need to see if they even have any abductor function that's salvageable, because if not, then you may have to do a constrained liner if you have no tension that can hold that hip in the socket. Otherwise, you may need to be prepared to fix a greater trochanteric fracture. You may need to be prepared to repair a torn abductor tendon. So you need to be ready if the patient has this type of gait, because it will hint at poor soft tissue tension and poor hip stability. When you go to get your radiographs, you need imaging of the hip, the entire femur, and the pelvis to assess for leg length, the hemipelvis, the femoral bone stock, and the presence or absence of osteolysis. Periprosthetic osteolysis is due to a histiocytic response. It's macrophage mediated, not osteoclast mediated. And it's usually to periprosthetic debris, usually polyethylene, occasionally titanium. So that's a very commonly tested thing on OITE or on boards. Ideally, you want serial films throughout the life of the prosthesis to assess for implant migration or any other structural changes that may be present and evolving. And you want to evaluate for intrapelvic cement or components that may require a separate retroperitoneal or intrapelvic approach to get at them. So once you get your radiographs, you want to assess the position of the acetabulum first. So supromedial migration indicates anterior column bone loss. Superolateral migration indicates posterior column or posterior wall loss. Kohler's line is what we're using to assess medial or lateral. Kohler's line is the medial wall, basically, of the native acetabulum. It goes from the most lateral aspect of the interior pelvic brim and the most lateral aspect of the obturator foramen, as seen in that yellow line below. Medial to that is protrusio, lateral to that is posterior column loss. If you see protrusio or a pelvic discontinuity or the presence of components intrapelvic, you may want to consider a CT angiogram and venogram, plus or minus a vascular consult before surgery to determine the relationship of the components that you need to go after in the iliac vessels to see if they're going to be at risk, which could potentially be deadly if you're unprepared for that. Additionally, when you assess the pelvis, you want to look at the teardrop, which is the medial wall, plus the inferior, anterior, and posterior column. It's the overlap of all of those structures that leads to the appearance of that teardrop. You want the inferior edge of the acetabulum to line up with the inferior teardrop. So if the hip center is high, that may tell you you may have to move the hip center. It may also tell you may have to lengthen legs to get things equal. So you need to look at all of those. Ischiolysis is a sign of posterior wall and posterior column integrity, which is that purple line. Pubic lysis is anterior wall and anterior column integrity. Superior dome is assessment of vertical migration. So now we're on to actually formally evaluating the presence of the components and structural defects that may be there. So we'll start with the acetabulum. So first off is the AAOS classification. This is more of a research-based classification just so that we can all speak the same language when we're reporting on these things. And essentially, it comes close to mimicking the Paprosky classification, but that one is much more predictive of treatment and therefore outcomes afterwards. So I'll leave this to you to hit pause and read it if you're interested. However, one of the criticisms of this is that it doesn't take into account quantity or location of the defect, which is why it may not be as helpful in terms of determining treatment. So now we move on to the Paprosky classification. So a Paprosky type 1 acetabular defect is a small, local, contained defect. So the acetabular rim, the anterior and posterior columns are all intact and supportive. Usually this is going to be something like osteolysis around the medial wall, or a defect from the previous surgery, or a hole left behind by a screw, or something like that, where you may not need to do anything. If you're cementing, you may need to just fill the defect with cement, or you may need to bone graft it, but at least still using a conventional cup should be fine. So a typical press fit, rim fit, or hemispherical revision cup with screw fixation as needed. The Paprosky type 2A is moderate superomedial migration of the acetabular cup. So the center of the hip joint is still less than 3 centimeters superior to the superior obturator foramen, and at least 50% of the host bone rim is intact. Remember, superomedial means anterior column lack of support. Treatment is a typical press fit revision cup, just increasing the size. However, if there's not enough host bone contact, or you can't quite get the hip stability, or you have to significantly raise the hip center with that, that's when you can go with the hemispherical revision, and then you'll cement a cup inside of that. You want to get screw fixation to make sure you have adequate purchase and provisional fixation into the bone, and you may need bone graft or cement to fill in any contained defects that are created. Type 2B is moderate superolateral migration of the acetabular cup center. Again, it's less than 3 centimeters of superior migration of the hip center compared to the upper obturator foramen. Again, you have greater than 50% host bone contact on the rim, and you may have a segmental superior rim defect because of that superior migration. Additionally, remember, this is posterior column loss. So this is one where if you do need to buttress or bone graft or augment, you've got to be thinking about the posterior wall. Whereas with a type 2A, you got to be thinking about an anterior column buttress. So it may change how you approach this hip, either an anterolateral or posterior approach. Treatment here, similar. Press fit cup if you can. If you can't, hemispherical revision. You want to get adequate screw fixation. Again, you may need augmentation, so have that ready to go. And you may need to cement something in. However, usually if you're doing any of those, by definition, it's no longer a type 2B, it's now a type 3 defect. Type 2C is moderate, isolated, medial migration of the acetabular cup, medial to Kohler's line. So the hip center hasn't been raised, but the cup is migrating intrapelvic. Treatment here is going to be a press fit, rim fit, if you can get a big enough one in there, or hemispherical revision, with or without bone grafting medial or a medial wafer augment to build that hip back out from the pelvis so that you don't run the risk of trochanteric impingement if you create coxa profunda by putting a hip back in too far medially. Now we're on to the type 3 defects. Type 3A is now superolateral migration. So the 2A is superomedial. So this does get a little bit confusing here, but now you have a much more destroyed defect. So the center of the femoral head is now greater than 3 centimeters above the obturator. You have significant bone loss. This is where now you're going to need a cup cage construct, a massive jumbo cup, or augmentation, or some combination thereof. So here's where you really need to have plan A, B, C, and D ready to go. Type 3B, superomedial migration. Again, anterior column loss. Either way, the principles are the same. You need to be ready to augment or graft. You may need a cup cage. Either way, you need big time extra pelvic exposures. You may need to be ready to fix the pelvis. If there's an impending pelvic discontinuity where extraction of implants or during your surgery, you may create one. So you have to be ready to go with that. You may also need to prophylactically fix the columns if you get in there and they're nearly about to fracture or unsupportive, even if they haven't quite fractured or lost that support as of yet. Type 4 now is pelvic discontinuity. Basically no connection from the ilium to the pubis and ischium. So a transverse acetabular fracture or something similar. Treatment here is going to be the same as 3B. Do whatever you can to get it in. Jumbo cup, cup cage, custom triflange component, anything like that. There's also something called distraction impaction, where basically if there's just truly an isolated crack and you don't have massive bone loss like we're showing in these pictures here, what you can actually do is ream for your cup, and let's say you ream a 64, you open a 68 cup and impact it in there. So you add about 4 millimeters, and what that does is it diastases the fracture, but because of that and because of the pelvic ligaments and soft tissues, it can only diastase so far. And what happens is then all those tissues tighten up and actually gives you great press fit of that component. And so then you'll get enough of that component to grow into the remaining bone that whether or not the fracture heals, you get stability, and it sort of accomplishes all of those goals. So that's one where you might want to consider that particular technique depending on how severe your defect is or how severe your bone loss is. Treatment principles of the acetabulum are, again, usually a porous-coated hemispherical or rim fit if the rim is intact cup with superior place screws preferred, but sometimes you need to put screws into the symphysis, sometimes you need to put them into the ischium. You want to at least 60 to 80% of the rim intact that you can get fixation appropriately. If not, you may have to do a distal femoral allograft, you may need augments, you may have to get creative, you may need a cage, things like that. Metal augments or cages are particularly useful if there's less than 40 to 50% of intact rim. Anterior and posterior acetabular walls are what provide the rim fit with the press fit technique. So you need cement or reconstruction if they are deficient. Structural, which is large, solid bone graft, is what helps share weight, versus particulate allograft fills cavitary defects. So again, depending on what you need, depending on where your defects are, if you have a defect that needs to be supportive to get cup fixation, you'll need structural allograft. If you have defects in the metaphyseal bone or something like that where you don't necessarily need it to be completely supportive, you need to fill a cavitary hole just to get something on the back side of the cup, that's where you'll use crushed cancellous or croutons or whatever you need in there. Failure rate is high if the cup is placed for direct loading onto allograft. As the graft is reabsorbed, the cup will tend to migrate. So usually you only want this as part of your weight-bearing or supportive portion. Otherwise, you may want to switch to metal augmentation. Greater than 50% contact with the allograft increases the risk of the allograft failure. So the metal augments are the alternatives to the graft. So the Zimmer porous tantalum trabecular metal can be used to recreate proper hip position. This is one company's solution and the first one that came out with a lot of these. And these were actually helped to be developed by Paprosky and a couple guys at Mayo Clinic that were part of this classification system as well. Now most companies have their same Me Too products that solve all of these same problems. So you can use whoever you happen to be comfortable with, and they all have great solutions for it. The one advantage to the Zimmer components and why I've included them in here is because trabecular metal is soft, and it's softer than titanium. So number one, its modulus of elasticity is closer to bone, so you tend to get a little bit better bone press fit initially, as well as bone ingrowth eventually. More importantly though, and why I like this system, is with that softer metal, you can get out a carbide or diamond tipped burr and contour these. So these are made for one size fits most, but if they don't quite fit the pelvis or the defect that's there, you can actually burr them down and get them to fit it. Whereas with the titanium components, you can't. The titanium's too strong and you'll go through 10 burrs just to make 1 millimeter of difference. So these are almost customizable intraoperatively if needed. Another potential is the use of wire mesh, which can be used to convert a segmental to a cavitary defect. So rather than structural allograft or a big metal augment, especially in this particular one where you have a pelvic discontinuity with really no bone supportive for where you want to put a cup, you can use this wire mesh to create that contained defect, then fix it into the adjacent bone to anchor it, and then you cement in a cup inside of that. So these can be useful as well to create pelvic anatomy to build off of for your revision. Reconstruction with an anti-protrusio or tri-flange cage fixed to the ilium with screws has a higher success rate for these cavitary deficiencies, with or without morcellized allograft filling the defect behind that cage compared to the mesh. So that's where the cage starts to come in. The cage gets fixation in the ilium typically, but it can also get fixation pretty much anywhere you need if you really need it. However, where these fail is in abduction pullout, and that's because with rocking and progressive motion in the hip, eventually the whole implant abducts and pulls out of the pelvis, especially if there's a constrained liner thrown in here, which quite often when you have defects this big, you're going to need because there's no soft tissue support to hold that hip in the socket. Previous high-dose pelvic irradiation are poor candidates for press-fit systems. So sometimes you're revising this because of aseptic loosening in the presence of an irradiated pelvis for prostate cancer or lymphoma or something like that. Even though initially you may get excellent scratch fit with your initial press fit, there's no bone ingrowth potential. So those are just ticking time bombs. So when you have that, have a cage ready if you need it, but really more than anything, have cemented components in mind. If you score the backside of the polyethylene cup with a burr or with a knife, it'll help interdigitate the cement a little bit better. You want to fill cavitary defects with bone graft or augments, as we talked about. If there's significant bone loss, you may need a jumbo, so greater than 66 millimeter hemispherical cup that can be used to maximize implant-to-bone contact. However, the hip center may need to be raised when you do that. But what you do is you come back into those cups and you cement in your liner. So you may be able to cement the liner back down low with a larger cement mantle superior than inferior to recreate an appropriate hip center. You want to exchange the femoral head at the time of acetabular revision, even if you're not touching the femur. And that's because usually you're going to damage or ding it during dislocation, during retraction, something like that, where you may lead to third body wear if you put that dinged head back in. So you do want to replace the head no matter what. But I can tell you from an exposure point of view, you want to remove the head anyway because it just gets in the way the whole time. Bulk allograft or metal pelvic reconstruction may be needed depending on how severe the defect is. And then, of course, hemipelvectomy, whether internal or external, may be the last resort. So now we'll move on to the femur. Similarly, there's an AAOS classification, again, mostly used for research purposes to be able to explain and talk about defects using the same language. But again, it doesn't take into account quantity or loss of bone and fixation options. So it's less important in terms of treatment options. So once again, Paprosky hit the nail on the head and has the best femur classification in terms of supportive bone to help predict what you might need in order to treat and reconstruct the femur. Type 1 is a segmental loss with adequate support. So this would be something like a failed hip resurfacing or revision due to component malposition as opposed to loosening, where you still have intact bone. Everything is almost as a normal original hip, and so you can just put in a normal press fit or cemented stem as you would in any other femur without having to really adjust anything or have any additional special instrumentation needed. A type 2 defect is now where you have an unsupportive metaphysis. So you can see the osteolysis present proximally in this femur. You don't want to rely on that to get your fixation. Number one, you may have poor ingrowth potential there. The bone may not be super viable. Number two, because of that defect compared to how robust the canal still is, you may get a significant mismatch in the sizing of the implant in the metaphysis versus the diaphysis that may lead to subsidence. And then finally, with how thin that is, if you go to press fit something in that gets scratch fit in that area, you're likely to fracture them. So this is sort of unsupportive bone. You don't want to rely on it. It means you need to bypass it. So you have to start getting fixation down the shaft. So what you need is either a huge metaphyseal filling and fitting one, as we just talked about because of that mismatch, or you need to go to a modular component. So the DePuy SROM was sort of the first thing that came around that was successful that did something like that. Or you need to start getting diaphyseal fixation with either a fully porous coated stem or a double tapered fluted stem. Subended components usually are a poor choice here because of the lack of bone in the metaphyseal area to get interdigitation unless you're planning on cementing far down the shaft or using a longer stem than usual. Modular implants, the problem with them is they tend to fail at the implant junctions due to the failure of the bone to load share. So all the load gets transferred to the implant, and then at that junction, that's a weak spot, and then eventually it can crack and break. So you may want to support it with structural allograft, with a plate and wires, things like that to enhance the load sharing or prevent excessive loading onto the implant. A type 3A defect is going to be severe metaphyseal damage with no metaphyseal support, but greater than 4 centimeters of isthmus contact can be obtained within the shaft of the femur. So then the treatment is a long stem, modular or monoblock, femoral component that gets fixation in that diaphysis. Survival is significantly lower if the bone loss extends greater than 10 centimeters distal to the lesser trochanter or canal diameter is greater than 19 millimeters, these so-called stovepipe femurs, and that's because fixation in those canals is also suspect. So that's where you'll need to buttress with plate and wires, structural allograft, or resort to proximal femoral replacement. Type 3B is severe metaphyseal damage with no metaphyseal support and less than 4 centimeters of intact isthmus. This is where you'll need one of those long stems plus support for sure, whether it's, as in these pictures, with structural allograft and cerclage wires, or a plate and cerclage wires, or distal fixation with cement up and down the whole femur, or impaction grafting into the femoral canal, or proximal femur replacement. So this is where the surgeries get bigger and bigger. Finally, you have a type 4 with severe metaphyseal damage, no metaphyseal support, and no isthmic support. That's where you have to bail out to proximal or total femoral replacement. When you go in to revise the femur, if it remains well fixed but has to come out for any of various reasons, you may need to perform an extended trochanteric osteotomy. What this is that picture in the lower right-hand corner of your screen where you cut down the femur and clamshell and crack that open basically so that it opens like a taco shell, get the stem out, and then you can cerclage it closed at the end. Once you do this, you've created an unsupportive metaphysis, so you've obligated yourself to getting distal fixation into the diaphyseal isthmus. So I put on here my preferred technique for how I perform this. This way you can come back to this PowerPoint and just freeze it right here and you can read about it. But there are certainly many ways to skin a cat. Several other people do this very differently, but this is kind of how I accomplish it quickly and easily. Treatment principles on the femoral side of things is an extensively porous coated long stem prosthesis may be preferred in certain situations where you need long fixation, especially when you have an unsupported metaphysis and a partially unsupported isthmus like in the 3B defects. So that's where you need to have those prepared. Otherwise, the double tapered fluted stems are now sort of the gold standard for treating bone loss and distal fixation. You can consider cementing, but you'll need to create contained defects in order to do that, and usually you need a very long stem, and you're cementing almost all the way into the distal metaphysis of the bone. The stem should bypass by 2 to 3 cortical diameters basically any defects or stress risers. So if you perform an extended trochanteric osteotomy, you got to go 2 to 3 cortical diameters below that. If you have defects or fracture extracting the stem, something like that, you got to bypass it all. If you're using modular components, they may fail or fracture at the junctions, especially in obese patients, especially in poor bone stock. So you may need to augment the bone or the fixation at those modular junctions. You want at least 6 linear centimeters of direct cortical contact with porous coating if you're going to go with a fully porous coated stem. You may need to go to a calcar replacing stem. What these do is when you have severe proximal femoral bone loss to the level of the lesser trochanter, you can replace the calcar by replacing up to 30 millimeters of length there without having to resort to a proximal femoral replacement. If greater than 30 millimeters are needed, that's where you go to the proximal femoral replacement, or you would have to do a calcar replacement with an allograft prosthetic composite or some sort of other structural support there. Straight stems are usually used as long as you're staying less than 175 millimeters. Otherwise, if you go greater than that, the bow of the femur will cause that straight stem to impinge on the anterior cortex, which will either hurt or lead to fracture. So when you go longer than that, you typically need a bowed prosthesis or a prosthesis with an anterior flattened bevel that avoids poking into that anterior cortex. If you're cementing, you want your mantle to be at least 2 millimeters circumferentially, and you want to avoid cementing beyond the isthmus, basically because you can't pressurize in that area anymore. However, if you have a really long stem in there, that's the only option that you have, and you have to do it. The hard part with that, though, is they're almost impossible to revise. If that fails, you've now obligated them to a total femur replacement. So usually you're doing that in a patient where perhaps their life expectancy isn't fantastic, where it's unlikely that this will fail in their lifetime. Allograft prosthetic composites can be used to replace massive defects. where essentially you take an allograft proximal femur, put in a normal hip replacement just like in this, so you can see where they have that transverse junction between the allograft proximally and the host bone distally. Then they've put a femoral strut with cerclage wires around that to buttress that junction, and then they put in a long, fully porous coated cylindrical stem to bypass all that. The advantage to that is it gives you a greater trochanter, usually with small attached tendons that you can sew the native tendons back to. So you may get better function afterwards, because sewing tendons back to a metallic prosthesis usually don't heal very well. Obviously, last resort here may be a girdle stone or a castle resection arthroplasty if it just can't be rebuilt anymore, but you want to retain the leg. However, if there are enough problems or an emergency situation, amputation may need to be done. And so that's it for Revision Total Hip Arthroplasty. I'll leave you with this photo for my Pacific Northwest Pride slide, which is the view from Mary's Peak, just south of Corvallis, looking towards the ocean there in the background, just above the cloud layer, actually. So Mary's Peak is the highest point in the coastal range in Oregon.